Hello and welcome to the topic Obstructive Sleep Apnea in the Respiratory Medicine module. By the end of this topic, you should be able to define obstructive sleep apnea, discuss the epidemiology of obstructive sleep apnea or OSA, outline the pathophysiology and causes of OSA, outline the classification of OSA, describe the clinical manifestations of OSA, outline the investigations, and discuss the principles of management as well as the complications of obstructive sleep apnea. Let's get started. Obstructive sleep apnea refers to the episodes of complete or partial upper airway obstruction during sleep. In episodic apnea, there is oxyhemoglobin desaturation and arousal from sleep. The prevalence of obstructive sleep apnea in the United Kingdom stands at 4% for men and 2% for women in their 50s. Between the ages 30 through 60, obstructive sleep apnea affects roughly about 9% of men and 4% of women. Incidence generally increases with age and obesity. Physiologically, pharyngeal muscles, that is the hyoid muscles, genioglossus, and muscles of the palate work to maintain airway patency, ensuring that inspiration occurs smoothly. When the activity of these muscles are increased during inspiration, there is stiffening and dilatation of the upper airway, which counteracts negative airway pressure. During expiration, there is reduced activity of these muscles. As the pressure inside the airway is positive, there is a reduced tendency to collapse. Various factors influence and control the activity of the pharyngeal dilator muscles, and these include the motor nuclei, carbon dioxide and oxygen pressure, wakefulness drive, and negative intrapharyngeal pressure. A narrow pharyngeal cross-sectional area, which could be due to obesity, tonsillar or adenoid hypertrophy, or even nasal congestion, leads to narrowed upper airway. In this situation, the upper airway experiences an increase in airflow velocity and a decrease in pressure within the cavity. Therefore, the airway is more likely to collapse. When the upper airway collapses, it triggers a vicious cycle that worsens when ventilatory efforts persist against the closed airways. An increased partial pressure of carbon dioxide with corresponding hypoxia leads to increased respiratory and ventilatory drive. As the airway patency is restored, overcompensated ventilatory efforts then reduce partial pressure of carbon dioxide. The brainstem detects this change and hence reduces respiratory drive. Eventually, this insufficient ventilatory effort causes the upper airway to collapse again. Structural causes of obstructive sleep apnea include polyps, septal deviation, tumors, trauma, and stenosis. Retropalatal obstruction such as facial elongation, posteriorly placed palates or uvula, and adenotonsillar hypertrophy are also possible causes. Another potential cause is retroglossal obstruction due to macroglossia and/or tumors. A high arched palate may also contribute to obstructive sleep apnea. Syndromes such as Marfan syndrome, Pierre-Robin syndrome, and Down syndrome also predisposes an individual to obstructive sleep apnea. Non-structural causes encompasses factors such as obesity, smoking, and sleeping in a supine position. Other notable causes are hypothyroidism, acromegaly, neurologic syndromes, and genetics. There are various classifications that have been used to categorize and assess cases of obstructive sleep apnea. The Epworth Sleepiness Scale assesses expectations of dosing in various situations. The Multiple Sleep Latency Test measures the time taken to fall asleep in a dark room. The Apnea-Hypoapnea Index accounts for the sum per hour of episodes of apnea and hypoapnea. Lastly, there is a stop bank questionnaire that can be used to screen patients who we suspect having obstructive sleep apnea. Symptoms of obstructive sleep apnea stems from disrupted sleep. Common complaints include excessive daytime sleepiness, poor subjective sleep quality, insomnia, inattention, and poor concentration. Recurrent central apnea and oxyhemoglobin desaturation can precipitate paroxysmal nocturnal dyspnea, morning headache, and nocturnal angina. Other symptoms include loud snoring, gasping, choking, and interruptions in breathing during sleep. Obesity, a high arched palate, crowded oropharyngeal airway according to the modified Malampati classification, a large neck, and or waist circumference and systemic hypertension are some factors that should prompt association with obstructive sleep apnea. Signs such as pulmonary edema, bilateral lower limb swelling, displaced apex beat, and elevated JVP point towards the development of heart failure, which is a possible complication of obstructive sleep apnea. Pulmonary hypertension often presents as a loud and palpable P2. In acromegaly, there is typical enlargement of extremities, coarsening of facial features, prognathism, macroglossia, thick lips, enlarged nose, protruding jaw, protruding brow, and spaced out teeth. Delayed reflexes, loss of one-third of the eyebrows, and edema around the eyes are typical signs of hypothyroidism. As with diabetes mellitus, findings include acanthosis nigricans and peripheral neuropathy. Signs of stroke include unilateral weakness or sensory loss, aphasia or dysarthria, ataxia, nystagmus, loss of balance, visual problems such as emeresis fugax, diplopia, and homonymous hemianopia. Low testosterone will manifest as low libido, erectile dysfunction, and small testicular size. Diagnosis is based on polysomnography, where the apnea-hypopnea index records at least 15 episodes per hour or at least 5 including other symptoms and/or comorbidities. In a multiple sleep latency test, sleepiness and alertness is measured. Severity can also be assessed with lab parameters. Serum bicarbonate is typically elevated. Arterial blood gas analysis will reveal hypercapnia and hypoxemia, while FBC may unveil polycythemia vera. Lung function tests may demonstrate a restrictive pattern. Chest X-rays and echocardiography may show signs of heart failure and/or pulmonary hypertension. An ECG may also reveal cardiac complications. This is what's seen on an ECG with a patient who we suspect having obstructive sleep apnea. Take note of the right ventricular strain, right ventricular hypertrophy, and the right axis deviation, which point towards the evidence of pulmonary hypertension. A fiber optic endoscopy done while patient is awake can be used to rule out hypertrophic lingual tonsils. Thyrotropin tests are able to identify hypothyroidism, which may be associated with obstructive sleep apnea. Now let's take a look at measures to manage obstructive sleep apnea. Weight loss is generally advised to overweight patients, while continuous positive airway pressure is the first-line approach for moderate to severe obstructive sleep apnea or hypoapnea syndrome. Intraoral devices used for mandibular advancement can be used if continuous positive airway pressure is not tolerated, or in the case of mild obstructive sleep apnea or hypoapnea syndrome. If there is excessive daytime sleepiness or somnolence, upper airway surgery is considered, and do not forget to remind patients to inform the Driver and Vehicle Licensing Agency or DVLA. Patients should be educated regarding their condition and advised behavioral modifications such as weight loss, practicing good sleep position, avoiding alcohol, and medications that may exacerbate their sleep apnea. A short-term complication of obstructive sleep apnea is impaired glucose metabolism. In the long run, several cardiovascular diseases may occur, and these include hypertension, dysrhythmias, myocardial infarction, and heart failure. The patient will also be prone to developing depression and getting involved in motor vehicle accidents due to excessive daytime sleepiness and decreased attention. Cognitive function is also impaired, and patients often have low arousal, executive attention and alertness. Besides that, patients may develop sexual dysfunction and metabolic syndrome. Ultimately, there is increased mortality predominantly due to cardiovascular diseases. Now, to summarize, obstructive sleep apnea refers to episodes of complete or partial upper airway obstruction during sleep. Prevalence in the UK stands at 4% in men and 2% in women in their mid-50s. That being said, incidence increases with age and obesity. The narrow pharyngeal cross-sectional area causes the airway to be rather collapsible. The resulting hypercapnia and hypoxemia triggers respiratory and ventilatory drives. Causes may be structural, non-structural, endogenetic among others. Symptoms include disrupted sleep, recurrent central apnea, and symptoms of oxyhemoglobin desaturation, loud snoring, gasping, choking, and interruptions in breathing while sleeping. Diagnosis can be made based on the Epworth Sleepiness Scale, multiple sleep latency test, apnea-hypopnea index, and stop bank questionnaire. Obesity, a high arch palate, grade 3 or 4 of the modified Malambati classification, large neck or waist circumference, systemic hypertension, heart failure, pulmonary hypertension, hypothyroidism, acromegaly, and low testosterone as well as stroke signs are all diagnostic clues and associated with obstructive sleep apnea. The severity can be assessed with sleep studies alongside other parameters such as serum bicarbonate, thyrotropin, arterial blood gas, a lung function test, and ECG. Imaging modalities may also aid in providing a complete picture. Management of OSA include continuous positive airway pressure therapy, intraoral devices, upper airway surgery, and behavioral modifications. Complications are impaired glucose metabolism, cardiovascular sequelae, motor vehicle accidents, depression, cognitive dysfunction, mortality, metabolic syndrome, and sexual dysfunction. We have come to the end of this topic. Thank you.